linking into my talk today. My talk is about reducing the risk of squamous cell carcinoma development by treating actinic keratosis. I'm Girish Gupta. I'm a dermatologist in the capital city of Scotland, Edinburgh. And this is the skyline of Edinburgh with Edinburgh Castle in the background. I've listed my interests and funding that I've received. To understand actinic keratoses and risks of squamous cell carcinoma, one needs to understand the prevalence of both diseases. They are common and they're prevalent in those with skin types 1 and 2 predominantly, and those who live in sunny climates. We know from previous literature that anyone aged over 40 has a prevalence of about 10 to 25% if they live in the northern hemisphere, and this prevalence increases substantially for those who live in Australia, with more than 40 to 50% of individuals affected with actinic keratoses over the age of 40. But what about the prevalence of actinic keratoses in the United Kingdom and Ireland, where I practice? Historic literature shows the prevalence in Wales, highlighted by number 1, more than 2 decades ago, showing that patients over the age of 60 had a prevalence of about 23%. Again, about 2 decades ago, it was noted that patients in the west of England had a prevalence of about 15% in men and less, 6% in women, and in those aged over 40 years of age. And this prevalence increased with age, and those aged 70 or more had a prevalence of 34% in men and 18% in women. So we know that actinic keratoses are more prevalent in men and more prevalent with age. And finally, the last prevalence study was from the west coast of Ireland. And it was an interesting study because it showed that people as young as 21 and above had a prevalence of about 11%. And again, they showed that with age, this prevalence increased. And in those aged 60 or more, the prevalence was very high at nearly 80% presenting with actinic keratoses. So it is a very prevalent disease, and with it come a lot of annual visits to dermatologists. And is estimated then that in the USA, more than 5 million visits were made in those over the age of 45 years who had actinic keratoses. And this prevalence has increased with time. And there are a few studies, there aren't many in the literature, but there are a few studies that have looked at the prevalence of actinic keratoses over time. And this study, published in 2018, showed that the prevalence increased by about 15% from 2007 to 2015. And that's what we're seeing in our own population. So I know that I am seeing patients that are younger. I'm certainly seeing patients with much more actinic damage to their skin, and I'm seeing a lot more women with actinic keratoses than I did 2 decades ago. So actinic keratoses are common. They represent chronic disease, and at present, we have no cure for actinic keratoses. And when we observe patients with actinic keratoses, they have 3 evolutionary possibilities, and these are not mutually exclusive. So some of the actinic keratoses will spontaneously clear. The majority will persist and increase in number, and some will progress into invasive squamous cell carcinoma. A number of studies have looked at this risk, and the one study that I've quoted here from 2013 shows that the risk of progression into invasive squamous cell carcinoma is anywhere between 0 to 0.075% per lesion per year, which equates to about a 2.5% risk at year 4. So the risk is low. Dermatologists who are against treating actinic keratoses to reduce this risk further often state this low risk. And to reduce this risk further, one would have to treat many patients with actinic keratoses to make a substantial reduction in this risk. To understand progression, one also needs to understand the prevalence of squamous cell carcinoma. And the figures for prevalence from England are approximately 22.6% per 100,000 person years. A study from Scotland in 2010 showed that the prevalence of squamous cell carcinoma has increased by more than twofold from 1979 to 2003. And we know from current practice that this increase continues. An important study from the Dutch group published just last year in 2020 showed that the risk was higher than that in England with 40 per 100,000 person years in 1989. And this increased by 2.5-fold to 107 per 100,000 person years in 2017 in males. But more importantly, this rise was much more significant in women, where the rise was from 13.9 to 68.7, nearly a six-fold increase in females developing squamous cell carcinoma. And again, we are seeing this in our current clinical practice. We are seeing many more older women presenting with squamous cell tumors. And so those that are proponents for treating actinic keratoses will say that with this rise in squamous cell carcinoma development, we should be treating patients with actinic keratoses. But in order to treat a large population, we also need to be mindful of the costs that this will incur. A study from the US showed that more than 15% of all medical costs were for treating actinic keratoses and keratinocyte cancers. And the estimated costs were $1.68 billion for treating actinic keratoses and $4.59 billion for treating squamous cell carcinoma. And this was published in 2017. Now, when we break this down per patient, then the cost for treating keratinocyte cancers was estimated to be $791, and for treating actinic keratoses, $143. But this study does not detail the costs for preventing squamous cell carcinomas, but gives us an idea, a flavor of the costs for treating both conditions. The only study that has looked at the cost benefit for treating actinic keratoses and preventing squamous cell carcinoma is this study published in the Journal of the American Academy of Dermatology in 2018. And this was a large American study of veterans who had had keratinocyte cancers. In fact, they would have had to have two cancers over a 5-year period to be enrolled into this study. And what they looked at was the costs of treating patients with squamous cell carcinoma and actinic keratoses over a 3-year period with one course of treatment with 5% 5-fluorouracil on the face and ears. So these patients were treated once only and then followed up for an average of 3 years. And what they showed was at 1 year, the control arm, so this was the placebo arm, had a higher mean number of treatment encounters for squamous cell carcinoma than the intervention arm. And these were patients treated with 5% 5-fluorouracil. Also at 1 year, the intervention arm had lower treatment and dermatology costs compared to those in the control group. And at 3 years, the intervention arms, so those treated with 5% 5-fluorouracil, incurred a lower cost per patient, and this cost was $771 less per patient when they were treated with 5% 5-fluorouracil. But there are a lot of caveats with this study. Firstly, this was not powered to look at cost. This was an observation study, albeit randomized, but it was still an observation study over a 3-year period. They only looked at the higher risk disease. As I mentioned, these patients had to have keratin site cancers to be enrolled into the study. And also these patients had large field change. So they had higher risk actinic damage to be enrolled into the study. And we know that there are no studies at present looking at the cost-benefit model in preventing primary squamous cell carcinoma, but we have this one study that has looked at prevention of secondary squamous cell carcinoma. And as I mentioned, they looked at the higher risk disease as shown in the right, not the low risk disease as shown on the left. So on the left, this patient has some actinic dysplasia with the few scattered actinic keratoses. But on the right, this patient has lots of actinic keratoses with large areas of field change. And that's the sort of patient that was enrolled into their study. And I think it's important to define high-risk disease because perhaps it's this group of patients that require further active treatments to try and reduce their future risks of developing squamous cell carcinoma. And I've tried to do this on this slide where I have specified the patient features and the lesion features that have some degree of evidence to show that they are at higher risk of developing squamous cell carcinoma. So just to concentrate on the patient-specific features, had keratocyte cancers are at high risk. We know this from literature. Those who are immunosuppressed, particularly those who are in the organ transplant recipient group, so they have pharmacological immunosuppression, and those who have other immunosuppressive diseases such as underlying malignancy, in particular chronic lymphocytic leukemia, and of course those with HIV. And then there are lesion-specific features. So we know that patients who have large field change are at increased risk, and those patients have multiple thick, confluent, inflammatory, or possibly painful actinic keratoses. Those with higher disease severity, and I will talk about this in a bit more detail, and those with large field areas of subclinical disease. So just to delineate some of the clinical high-risk features, we know from previous literature that patients who have a larger number of clinically diagnosed actinic keratoses have a higher risk of developing squamous cell carcinoma. And it is thought that patients with an average of 7.7 actinic keratoses have a risk of about 10% of an actinic keratosis progressing to a squamous cell carcinoma over a 10-year period. But lesion counting or actinic keratosis counting can be difficult. And we know from studies that often other disease entities are thought to be actinic keratosis. And with this in mind, we proposed a scoring system called the Actinic Keratosis Area and Severity Index, ACASI. This is based on the area of actinic damage on the head, and it is a composite score addressing the distribution of actinic damage. So this looks at addressing field change, the amount of erythema that is present, again addressing the field change, the thickness of the actinic keratoses. Now these scores are added up as shown in this worked example. the percentage of the affected area is then calculated, and there is a corresponding area score. The sum of the composite scores is added to the area score to give a subtotal, and this is multiplied by the area coefficient, similar to the PASI score in psoriasis. A total score for each site is calculated, which then is added to give a total ACASI score. And this can be anywhere between 0 for patients with no disease and 18 for those at the very severe end of the spectrum. And the ACASI is an interesting and important score, as it has been shown in this publication from 2018 to correlate with the incidence of squamous cell carcinoma. And in this paper, patients with squamous cell carcinoma had a higher ACASI score, and this was an average of 6.9, over patients with basal cell carcinoma who had an ACASI score of 3.3 on average, and this was higher than those patients who did not have a keratocyte cancer. So for the first time, we can show that patients who have higher ACASI scores are at the highest end of the spectrum, and this correlates with squamous cell carcinomas. And we may therefore be able to use ACASI to risk stratify our patients into those at higher risk of developing squamous cell carcinoma than those who are not. ACASI has been validated in 4 studies, and I've listed 3 here, and 1 I will discuss later. So we know that ACASI is reproducible, and there was significant correlation between the 4 observers. And it also significantly correlates with the total lesion count. And this paper was published in 2018 in the British Journal of Dermatology. What about ACASI and its use in treatment monitoring? So the 2 studies I've listed here show that ACASI scores improved with treatment with diclofenac gel. And in this study, diclofenac gel significantly diminished the ACASI score with 84% improvement in 3 months, with an average ACASI reduction of 31%. And the final study that I mentioned is that photodynamic therapy also leads to significant ACASI improvements with 97% improvement at median follow-up of 96 days with photodynamic therapy. And this was conventional photodynamic therapy and not daylight photodynamic therapy. But this paper is interesting, because for the first time, we have shown results based on different ACASI scores. So here we have ACASI 50, in other words, 50% improvement, and 73% of the cohorts had this. ACASI 75, so that's 75% improvement, and just about 50% had this. And ACASI 100, which is total clearance, and about 40% had total clearance. And I think moving forward, we need to have some sort of scoring like this, similar to psoriasis scoring, when we try and evaluate further treatments for actinic keratoses. Now, I mentioned clinical disease. What about subclinical disease? Because we know that patients who have subclinical disease have an increased risk of cancer development, and this is not new. This is not a new concept. We know in actinic keratoses, these mutation fields can be large, which increases our evidence for field-related therapy. And this is a patient of mine who had actinic keratoses, as you can see here, but you can also see that the skin around the posterior aspect of the scalp, including the hairline, has a fair amount of erythema. There is some skin atrophy. And so this person will have a large area of subclinical disease, as well as the obvious clinical disease. And we tried to highlight subclinical disease previously using porphyrin. uptake. So in this case, on the left, this is a clinical image which showed actinic damage and the 1 or 2 actinic keratoses. And by coating this with porphyrins, leaving them for 3 hours, and then illuminating light, what we had hoped was that the dysplastic cells, the subclinical disease, would take up the porphyrins and be highlighted with pink staining, as one can see on the slide on the right, the photograph on the right. Unfortunately, the results were poor and the uptake was not visualized well. Nowadays, we can use reflectance confocal microscopy to look through the skin and see subclinical change. And this is a slide that Professor Palicani has donated. And on the left, one can see normal skin with normal honeycomb pattern. But on the right, one can see that the keratinocytes are mildly dysplastic for shape and size. So I think moving forwards, one will be using these techniques to look for subclinical disease more. So I've highlighted some of the clinical features that correlate with high-risk disease, but what about pathological and molecular markers in high-risk disease? Because if we can delineate these, then we can target our treatment for the higher risk end of the spectrum. It was thought that the thickness of actinic keratoses clinically correlated with squamous cell carcinoma. It was also thought that the thickness of actinic keratoses clinically correlated with the pathological change one saw. In other words, patients with thin clinical actinic keratoses were thought just to have basement membrane change. Patients with the very thick actinic keratoses were thought to have full thickness dysplasia. And this paper addressed this by looking at 892 lesions, comparing their clinical features to their pathological features. And what they found that only half of the lesions matched in clinical and histological terms. So in other words, patients with thin actinic keratoses should predominantly have mild basement membrane change. In other words, most of these patients should have AK1 change. But as you can see, only about a quarter of them had that. And in fact, the vast majority had moderate dysplasia throughout the epidermis. And then those with thick actinic keratoses, one would expect full thickness dysplasia, but as you can see, only about 14% had full thickness dysplasia. So in other words, there is very poor correlation between what one can see above the skin to what is found below the skin. So the clinical features are a poor guide as to what is going on. And we know that actinic keratoses, apart from the upward growth of dysplasia, have basal proliferations invaginating the dermis from the basement membrane. And these have been termed as crowding, where the atypical keratocytes crowd along the basement membrane, to budding. So this is Pro1 where there's crowding. Budding is termed Pro2. And then there are these papillae that invaginate into the dermis, and these have been termed Pro3. That actinic keratoses show these variable histological growth patterns. And this paper highlighted this. It showed that in 246 lesions, the vast majority had a degree of basal growth with crowding, in other words, Pro1, About half of them showed Pro2 change and about 18% showed Pro3 change. Where there was adnexal structure involvement, most of the patients had either Pro2 or Pro3 basal growth patterns. And our study showed that basal growth patterns in AK do not correlate with the established histological grading system. And the histological classification of AK should consider both the upward growth and the downward growth patterns when assessing actinic keratoses. And so why are these basal proliferations important? This paper, published in 2019 in the British Journal of Dermatology, assessed cutaneous squamous cell carcinomas for their basal growths. And what we have shown is that just over half of the lesions had actinic keratoses with histological grade 1 noted adjacent to the actinic keratosis. The majority of the patients had some basal growth pattern of involvement, with Pro1 basal growth pattern in about a quarter, Pro2 in about a third, and Pro3 change in nearly 40% of the cases. And in total, about half of the actinic keratoses showed extension into the adnexal structures. And where there was adnexal structure involvement, just about a half of these lesions had Pro3 change. In other words, squamous cell carcinomas are more commonly associated with marked basal proliferation, particularly Pro3 change, and with adnexal involvement. And along with this, they also have atypical keratocytes just at the basement membrane. In other words, AK grade 1 change. So dissimilar to what has been previously published, which has been that patients with squamous cell carcinoma are more likely to have full thickness dysplasia. This paper shows results that are contrary to that. I've discussed the clinical and the pathological features of high-risk disease, but what about mutations found in actinic keratoses and squamous cell carcinoma? In this paper, which looks at the signaling pathways and the metabolic pathways in these two disease entities, is yet to be published. This is in print in the JID. So I am going to concentrate on the signaling pathways, so the left area and not the right. In the blue are the mutations seen in actinic keratoses, and in the brown, the mutations seen in squamous cell carcinoma. And anything on the right of this black line is significant, and anything on the left is not. Anything in the checkered box shows differences between actinic keratoses and squamous cell carcinoma, and anything above the box shows no significant difference between the two diseases. So as you can see, both entities have large number of mutations in P53, MAPK signaling, Notch signaling, and P13K signaling, but there is no difference between actinic keratoses and squamous cell carcinoma. The one thing of interest, although it does not reach significance, is in TGF-beta signaling, and you can see that there is a difference between actinic keratoses and squamous cell carcinoma. So perhaps in the future, and clearly further work needs to be done here, TGF-beta may be an important molecular marker. And I think further work needs to be done looking at this with actinic keratoses with Pro3 and adnexal change around squamous cell carcinomas. So I've highlighted the clinical and the pathological high-risk features, and I think the treatment decisions that we as dermatologists make should be based on these risks and individualized. And when we see patients, we should engage and discuss the treatment goal. And our treatment goal should be, of course, to reduce the actinic burden, to improve the skin quality, and ideally to prevent squamous cell carcinoma, noting what I've said right at the start of the discussion, which was that most of our evidence is in preventing secondary squamous cell carcinoma over primary squamous cell carcinoma. And when we choose treatments, we need to know what treatments are available, which is the best, what is the effect, how long the effect lasts, what are the side effects, are the side effects uniform, and of course when we can reuse our choice. And I've highlighted this in the AK management algorithm, and as you can see here, right at the top, there should be a treatment decision made, and that's when the patients first present with actinic keratoses to our clinics. And as one can see, the decision to treat should be made on these high-risk features, patient choice, and symptoms. And of course, if none of these are present, then active treatment should be with just emollients and sunblocks. However, if they do have the high-risk features or they have symptomatic disease, then patients may go on to have field-based therapy, and I tend to use a lot more large field treatments than the other treatments for my patients. So I'm going to concentrate the last aspect of this talk by talking about prevention of risk. And when we see our patients with actinic keratoses, the one thing we need to address is whether they are immunosuppressed. Now, we know that the risk of actinic keratoses and squamous cell carcinoma increases in the organ transplant recipient group because of their immunosuppression. And there's a 15% prevalence in high-risk disease, 15% prevalence of high-risk disease in this group of patients, as shown in this study published in 2015. And this risk increases with the length of immunosuppression. So patients who are recipients of organ transplants and are immunosuppressed have high-risk disease, which is 4 times more likely to develop squamous cell carcinoma than low-risk actinic keratoses. And it is important to address this group and manage this group appropriately. So these patients will often have actinic keratoses clinically, but large subclinical fields of actinic damage. And this study addressed subclinical actinic keratosis and showed that imicamod 3.75% cream significantly reduced ACASI scores from baseline, with nearly 55% of patients having an ACASI score of 0 2 months after the end of treatment with 3.75% imicamod. In other words, they were clear. And these patients were followed up by reflectance confocal microscopy follow-up. So this slide shows the results of that study. And at T0, which is baseline, T1 is after the first 2-week cycle of imicamod, T2 is at 1 week after end of treatment, and T3 is 2 months after the end of treatment. And as you can see, all the scores of parakeratosis, scales, keratocyte disarray, inflammation, crusts and ulceration, all improved by the end of treatment. In fact, all improve 2 months after the end of study. So we can show for the first time by using RCM that 3.75% imicamod cream reduces subclinical actinic damage. And this slide not taken from the study, but provided by Professor Malvehi, shows this with change in the keratinocytes before treatment and after treatment with 3.75% imicamod. And as you can see, there's a lot of keratocyte disarray prior to the start of treatment, which normalizes towards the end of treatment. So when we choose a treatment, what we need to know is the efficacy of the treatment, the area of the application, the site of the application. Patients prefer short treatment durations, and of course, those with few or lower a rate of side effects. And this paper highlighted this. This was published in 2019 and showed that patients were prepared to accept some reduction in efficacy in order to reduce treatment burden. So patients were not exactly looking for 100% clearance if they had to endure long treatments or treatments that caused a fair number of side effects. So when I see patients, I try and explain to them that there should be an induction phase, and I have a number of options available as shown in the algorithm. And my aim is to try and achieve a high ACASI score reduction. So I want to show and I want to see that patients' actinic damage has improved markedly with the treatment that I have chosen. But then what I also want to do is have a maintenance phase, and that can be using the same medication again or using different treatments sequentially. And this is poorly studied in the literature. I know there are papers that show sequential therapy with cryotherapy and topical therapy and so on, but we don't know exactly when to start patients on sequential therapy or using the same treatment for the second or third time round. Even our guidelines don't highlight this. And this is taken from the British Association of Dermatologists Actinic Keratosis guidelines published in 2017 in the BJD. And they show that treatments could be either lesion-directed or field-directed, and of course, combination therapy. This is a busy slide taken from the British Association of Dermatologists guidelines that I've just mentioned. And what they looked at was the treatment shown here, the reduction in actinic keratoses based on a number of observational studies, randomized controlled trials, and meta-analyses. So these are not very comparable as they are an average. The cost per treatment. So 1 diamond is low cost, 4 diamonds is high cost. So this is cost based on a prescription of that treatment. And this is the average cost when one takes into account the staff time, the number of visits the person has, whether they go to primary care and secondary care, the flexibility of the regime, and whether it can be used in primary care. And as you can see, some treatments are not so expensive. So this is 5% 5-fluorouracil. And some treatments are a little bit more expensive, such as diclofenac gel and the imicamods. But this is just purely the cost of the prescription. But when we look at the overall costs, then these costs are very similar. So they don't help us guide our management. What about the flexibility? So as you can see, 5% 5-fluorouracil, imicamods, and diclofenac are fairly flexible in their treatment schedules. And most of these are also accessible in primary care. So, but perhaps most of our treatment should be with the large field topical therapies. This slide also looks at the efficacy, the ease of use, and the morbidity of that treatment based on the author's evaluation. So these were the authors of the guidelines. And what I want to do is just concentrate on a couple of items. So the confluent scalp row, as you can see, patients with confluent disease, so more of the higher risk disease, have similar results with 5% 5-fluorouracil, with diclofenac gel, with imicamod. So these treatment options would be very reasonable, along with PDT for those presenting with confluent scalp actinic keratoses. What about the more difficult sites like the backs of the hands and lower legs? And here, the best treatment options, according to the authors of that paper, were photodynamic therapy and then topical therapy, those with 5% 5-fluorouracil or acticaral. The way I approach my patients is to choose one of the large field treatments, that being those being PDT, and that could be conventional or daylight, diclofenac gel, 5% 5-fluorouracil cream, and 3.75% imiquimod cream. And I'm just going to highlight some of these treatments and the evidence behind them. So I'm going to concentrate first on conventional PDT, and that can be with aminolavulinic acid or its methyl ester. There are very few good randomized controlled trials, but where these exist, these show complete response rates with ALA PDT of 64% compared to placebo PDT at 11%. So we know that PDT works. And when ALA PDT has been compared to MAL PDT, the methyl ester, and placebo, the results show that ALA PDT was slightly superior at 78% clearance to MAL PDT at 64%. And in a randomized trial comparing MAL PDT to diclofenac gel, PDT showed superior results at 68% to diclofenac at 27% at 3 months. And at 1 year, the complete response rates were 55% in the PDT group as compared to 28% in the diclofenac group. So it seems that PDT has better results than diclofenac in field change. But what about daylight PDT? Conventional PDT can be difficult because the person has to go into hospital to have their actinic keratoses treated. But with daylight PDT, they could do this at home. And daylight PDT can also be given with ALA or its methyl ester. And where it is used is in those patients with large field change. They need to be able to apply the porphyrin. The day that they choose to have their skin treated should not be overcast. It should be clear. They should be able to sit out for about 2 hours, and it should be more than about 10 degrees centigrade. A previous study has shown that ALA, when compared to MAL daylight PDT, was non-inferior, with a complete response rate of about 80% with ALA PDT as compared to 76.5% with MAL daylight PDT. So both seem to be effective, and one is not better than the other when it comes to daylight PDT. Daylight PDT, of course, is very difficult to do in Edinburgh because what you really need are days like this. But unfortunately, often, particularly during the winter and autumn, our weather is a little like this. So we can only manage daylight PDT during our summer months. I'm going to move on to diclofenac gel. We know from a number of studies that it has moderate efficacy, but its advantage lies in its low morbidity. It gives less intense reactions than imiquimod or 5% 5-fluorouracil, and it has a high level of patient satisfaction, and patients will reuse diclofenac gel over some of the other treatments because of its good side effect profile. And where I use it is in those patients with thin, large field, scattered actinic keratoses. I'm going to move on to 5% 5-fluorouracil cream. It's an effective therapy for actinic keratosis. It is used widely by dermatologists. But despite its usage, a Cochrane review published just under 10 years ago showed that the evidence for its use remains poor. And there is no fixed schedule. There is a license indication, but there's no absolute fixed schedule. And often patients will need repeated or longer treatments. And patients will often experience significant side effects, as shown in this slide, where this person has used 5% 5-fluorouracil. They'd used it once a day, not twice a day, for about 4 weeks. And you can see the amount of inflammation and crusting that is likely to develop. And most patients do not like this reaction and will choose not to use the same treatment again if they require it. So what I do is I reduce the frequency, and I am now often using 5% 5-fluorouracil 3 times a week for longer, and I get very good results. And I've got a small cohort of patients that I am now collecting, and I'm addressing their actinic damage with ACASI scores. And so far, what I've shown, what I can show is that the ACASI scores decrease with this lower frequency of 5% 5-fluorouracil treatment. And this patient has had skin cancer previously, as you can see, treated with a graft and presented with hyperkeratotic actinic keratosis with field change, as you can see, going into the hairline. And this person was treated with Effidix cream 3 times a week for 3 months, and this is at 3 months. And he has continued on his intermittent regimen to keep his actinic keratoses under control, and over the last 2 years has had no further development of squamous cell carcinoma. I'm going to move to imicamod 3.75% and the evidence behind this treatment for large field reduction in actinic keratoses. And this was based on 2 vehicle-controlled, double-blind phase 3 studies with 320 patients recruited. They were at the higher end of the spectrum with up to 20 actinic keratoses present. Remember, most topical therapies recruited patients up to 10 actinic keratoses. And the treatment area was either the face or the scalp, and this was placebo-controlled, as shown here in the blue line, and in the red line is treatment with Zyclara 3.75% imicamod. And it's a 2-week treatment with 2-week rest phase and a second cycle of 2-week treatment. And as you can see, the numbers initially increase, and this is thought to be due to subclinical disease becoming more evident. The numbers then decrease after the end of the first treatment phase. They increase again with the second treatment phase to decrease. And compared to placebo, there was a significant difference between the vehicle group and the Zyclara group in their studies. But what about those patients at the lower end of the risk group compared to those with the higher risk disease, so those with more than 10 actinic keratoses? Were the results similar? And this study highlighted this very well. So those at the lower end of the spectrum with less than 10 actinic keratoses had significant difference between placebo and Zyclara. And this result mirrored those with more than 10 actinic keratoses. And as you can see, there was a significant difference between both placebo and Zyclara in the higher risk disease group. So it shows that 3.75% imicamod is effective regardless of the number of lesions present. And it is also shown that over a longer period of time, so this study looked at clearance of actinic keratoses in those that were followed up to a year following treatment. And as you can see, the numbers decrease following treatment and remain relatively static until the 1-year follow-up period. So it has, it is shown that it can clear both clinical and subclinical disease, and this disease remains relatively clear at up to 1 year following treatment. What about results of efficacy from recent years? I showed you efficacy results from 2017 from the British Association of Dermatology guidelines previously. This slide shows efficacy results for 5% 5-fluorouracil, diclofenac, 3.75% imiquimod, and ALA-PDT. And the complete clearance results are a range because, of course, they're based on a number of studies, as I've highlighted previously. But interestingly, at 1 year, the results are relatively similar at around about the 30% to 40% mark. So this doesn't guide us, this doesn't help guide us with treatment choice. So it was very interesting to see this paper published in 2019 in the New England Journal of Medicine, which compared 5% 5-FU to 5% imiquimod, MAL-PDT, and inguinal mebutate. And it was a randomized control study looking at reduction in actinic keratoses with one of the treatments. Their primary endpoint was that the person should remain free from treatment failure, which they defined as less than 75% reduction in actinic numbers. And the results at 12 months showed that 5% 5-FU was superior than 5% imiquimod, MAL-PDT, and inguinal mebutate. I know we do not have inguinal mebutate in Europe. This was the first good, large, randomized control prospective trial that showed that 5% 5-FU was superior to the imiquimod and MAL-PDT in the group of patients who had actinic keratoses, including the group that had hyperkeratotic actinic keratoses. And these are patients that we commonly see in our clinical practice, but often are excluded from clinical trials. There were some problems with the study. I think if this study was to be reproduced, then they should have compared the 5% 5-fluorouracil to the other large field treatments, this being diclofenac gel and 3.75% imiquimod cream. What about new treatments that are emerging? There are two that I've listed. The first is VDA 1102 ointment, and the second is terbinafine ointment. So the first one that I mentioned, the VDA 1102, is also called tuvatexib, and it targets the hexokinase molecule. Now, hexokinase is the first enzyme in the glycolysis pathway, and there are two isoenzymes. HK1 is found in normal cells and HK2 in mainly malignant cells, and this ointment targets the HK2 molecule. And via molecular processes, it triggers apoptosis. And it significantly affects malignant cells without affecting normal tissue. And HK2 is highly expressed in actinic keratoses, squamous cell carcinoma, and melanoma. And this efficacy table showed that in a phase 2A study, a small phase 2A study, once a day usage of this ointment at 10% at 4 weeks showed a median reduction in AK lesions of about 45%. And when this ointment was used twice a day, the improvement was much better at 74%. And there are ongoing studies with this topical treatment, and I think it'll be one to watch. The second treatment I mentioned is terbinafine. It has anti-proliferative effects. It inhibits the tubulin polymerization, and again, through a number of steps, it causes cell cycle arrest and cell death by apoptosis. It is being studied in actinic keratoses, in two identical randomized control vehicle control studies using tabanibilin 1% ointment once a day for 5 days and placebo. Patients had to have 4 to 8 clinically typical AKs on the face and scalp. And as I said earlier, this treatment was applied once a day for 5 consecutive days. The primary endpoint was complete clearance at day 57. And the secondary efficacy endpoints were partial clearance, so more than 75% reduction in AK lesions. And of course, the safety profile was also addressed. There were 702 participants across 62 American sites, and the demography was similar in the two studies. And 700 of these completed the study up to day 57, so there were very few dropouts. And this slide shows the results of the two phase 3 studies. And one can see that in both studies, there was 100% clearance of actinic keratoses in just under half in the first and just over a half in the second study. And when one looks at partial clearance, about 68% had partial clearance in the first, and just over 3/4 had partial clearance in the second study. There was no real systemic absorption. Compliance and concordance was over 99%, and most of the reactions were deemed to be mild and moderate, which rapidly improved around about day 8. And this graph shows the AK lesion counts throughout the period of the study and follow-up in the two studies that I mentioned. Vehicle is in the dotted line, and the solid line represents tabanibilin. And as you can see, there are significant differences between both groups, even as early as day 15. The side effect profile is good. These are, again, the two studies, and tabanibilin is in black and the vehicle is highlighted in green. And you can see the side effects increase up to a peak of about day 8 and then subside. These are composite scores of 6 local site reactions, and these are erythema, flaking, crusting, swelling, vesicles, and erosions. And the possible range of scores is 0 with no side effects to 18 with severe side effects in each of the scores. And as you can see, the scores are all around about 4. So there are very few side effects with this treatment. And I'm just going to highlight some of the features that one can see with this particular ointment. So this is day 1 within the treatment area. At day 5, you can see the erythema. Day 8, when the reaction should peak, and again, there's some erythema. This erosion was self-inflicted. Day 15, where this is starting to improve, and day 29, where a lot of the erythema has settled, and finally at the end of this study, the erythema has now cleared. So I've highlighted some of the new topical treatments that may become available to us in the very near future, and I know tabanibilin is going through its paces at the moment. But what about trying to reduce the risk of squamous cell carcinoma? Can any of our topical treatments do this? And is there evidence behind this? I'm going to go back to the study that I mentioned previously, and this was the Veterans Keratin Site Carcinoma Chemoprevention Trial. I showed the cost reduction. What I want to show now is whether this reduce the risk of squamous cell carcinoma development during the follow-up period. So it was a randomized, double-blind, placebo-controlled trial of topical 5% 5-fluorouracil compared to placebo in preventing keratinocyte cancers. And these patients, to be enrolled in the study, needed to have at least 2 keratinocyte cancers in the 5 years preceding enrollment. And what they showed in this large study was that 299 patients developed BCCs in the follow-up phase. 108 developed squamous cell carcinomas in the follow-up. There was no difference in the time to the first cancer, but there was a 75% risk reduction in those that were treated with 5% 5-fluorouracil than in the placebo-controlled arm. So this was the first study that showed that there was some degree of risk reduction in the higher risk group of patients that I've already delineated. And this was using 5% 5-fluorouracil once. So the question is, if these patients were treated every year, or maybe even twice a year, could the risk reduction be even more? And I think we need to do further studies to address this very question. There are some oral treatments that have also been shown to reduce risk of both squamous cell carcinoma development and actinic keratoses, and oral retinoids have been studied the longest. But there's poor evidence in the literature because most of the studies are large case series with very few good quality, large randomized controlled trials. And most of our results are derived from organ transplant recipient population. Most of the studies carry a high risk of bias. All studies so far have used lesion counts, and I've explained why lesion counts may not be the most appropriate, as not all keratotic lesions turn out to be actinic keratoses. Most of the studies with oral retinoids do not have clear endpoints, and most are short-term follow-up studies. The one study I think that has been relevant, published more than 2 decades ago, and this was a double-blind placebo-controlled trial in the renal transplant population, showed that there was a decrease in new squamous cell carcinoma in the acitretin group compared to the placebo group. And they also showed that there was a 13% decrease in actinic keratoses in the acitretin group compared to a 28% increase of actinic keratoses in the placebo group. So again, in the very high-risk population, retinoids seem to decrease the number of new squamous cell carcinomas and also actinic keratoses. So to summarize, oral retinoids reduce actinic keratoses by about 50%, and are usually started after patients have developed 2 or more squamous cell carcinomas, because that's where so far the risk reduction has been shown in literature. But what about starting oral retinoids after the first squamous cell carcinoma, or before a person has even started immunosuppression? These questions remain unanswered. The other oral treatment that is of interest is vitamin B3 or nicotinamide. And this paper, published in the New England Journal of Medicine, showed that not only did it decrease the risk of new squamous cell carcinoma development, the significance value was just 0.05, and this was at 12-month follow-up. But it also reduced the number of actinic keratoses, and at 12 months, there was a 13% decrease in actinic numbers, and this was significant. But again, we do not know what nicotinamide does at post 1-year follow-up. So does it still continue to work and reduce the risk of developing squamous cell carcinoma and the rate of actinic keratoses if nicotinamide was used for a longer period of time? In the very high risk group, combination therapy may be appropriate, but poorly studied. So in my cohort of patients who have a large number of squamous cell carcinomas, I would try and start them on oral retinoids. But there's very little evidence in the literature as to combination treatments, including nicotinamide with retinoids, and whether there's risk reduction. And what about combining them with topical therapy or PDT? And we now have a small cohort of patients who are on all three treatments. And I think time will tell as to whether combination therapy reduces the risks of squamous cell carcinoma development over single agent therapy. And again, trials are needed in this area. I want to highlight some of what I've discussed with a couple of cases, and this is a patient of mine who'd had previous keratinocyte cancers, and she presented with ongoing cancer development and a lot of actinic damage, particularly on her lower legs, a difficult to treat area, and she'd had treatment with a number of topical treatments which really didn't help. She was started on oral retinoids, and this is before treatment with oral retinoids, and this is at month 3. And I'm just going to show you some more slides, and you can see the hyperkeratotic lesions, and some of them look as if they have reduced in number with oral acitretin. And here one can see a reduction of some of the hyperkeratotic lesions, and here as well. And this slide shows the significant reduction in hyperkeratoses on the dorsal aspects of her foot, as shown here. And this is just a close-up of her ankle, which shows a decrease in the hyperkeratoses. So in this lady who'd had previous keratinocyte cancers, failed on topical therapy, but actually had improved with oral retinoids, and subsequently the rate of squamous cell carcinoma development has reduced, but not reduced to 0. And she will continue on oral retinoids, and I will treat her with photodynamic therapy or topical therapy in combination. My final patient is that of is a patient with quite marked hyperkeratotic actinic keratoses, and again he'd had keratinocyte cancer previously treated, as you can see, with a graft, and he'd had others treated as well. So he was at a high risk of developing further squamous cell carcinomas, and he'd been treated topically with 5% 5-fluorouracil and 5% imiquimod, and also with conventional PDT. And his whole scalp was treated with 3.75% imiquimod cream, and at week 2 he developed marked crusting of the area, but he was largely asymptomatic. And this is at week 4. So this is just prior to the start of the second course of treatment. This is at 2-month follow-up. He was asymptomatic. A lot of his actinic keratoses had cleared, but the one lesion that had remained was a biopsy-proven squamous cell carcinoma, and this was excised. He's now been followed up for 3.5 years, and he's developed no further squamous cell carcinomas. So by treating his actinic damage, there is a possibility that he will remain free of developing further squamous cell carcinomas. And my aim is to repeat therapy should he develop further actinic damage. And this is a slide before treatment and at the end of follow-up. So our AK treatment landscape has changed from having diclofenac, 5-fluorouracil, imiquimod cream, and now potentially includes new topical treatments that are emerging and are encouraging. And to summarize my talk, what I have shown is that the evidence for primary prevention of squamous cell carcinoma is poor, but there is stronger evidence for secondary prevention. And I think where there is higher risk disease, both clinically and pathologically, then the actinic dysplastic field requires therapy with field treatments. Cost-benefit studies are encouraging for the higher risk disease, and our aim should be for long-term control of disease. Thank you.